All right, COPD. I'm not really sure, but COPD is probably one of my favorite patients to take care of. I like the patho. I think it's kind of cool. Not for the patient, but it's it's a great patient to take care of. So COPD is preventable and treatable. Um, it depends on what stage, which we'll review. But it's associated with chronic inflammatory response. So how do you prevent it? All right. How about that personal protective equipment from environmental lung diseases? What's another risk? Yes, cigarette smoking. Okay. It can also be called chronic bronchitis. Um, and emphysema is another name for it. So again, risk, air pollution, infection, genetics, or antitrypsin deficiency. Uh, who was it? The old Superman, the Superman from the 80s. Can't think of his name right now. He died from the spinal fracture. His wife, I believe, died from antitrypsin COPD. Never smoked a day in her life, and had COPD. It is the fourth leading cause of death in the U.S. More women die than men. What else? Death rates in Hispanics are lower than in any other ethnic group. I can't tell you. I've read a lot about why that was. 80 to 90% of COPD deaths are related to tobacco smoking, and of clinically significant airway obstruction develops in 15% of the smokers. So here's your pathophysiology map. You guys can look at that a little bit. I want to talk to you more about the clinical manifestations. So it's the chronic intermittent cough, wheezing, chest tightness, fatigue. The barrel chest is, you know how the body is always compensating for things? The barrel chest is that compensatory mechanism that the musculoskeletal system does to help with air. The tripod position is how a person might sit in order to have the maximum increase of the lung capacity. Hypoxemia is common. They're living without oxygen. Weight loss, because again, if you can't breathe, you can't eat. Some of the complications: cor pulmonale, COPD exacerbations, acute respiratory failure, depression, anxiety. About 50% of COPD patients experience depression because if you can't do your ADLs without getting out of breath, you don't want to do them, and you get depressed. Patients can get anxious. So teaching pursed lip breathing is important. That's a nursing intervention that you can do to teach patients. Let's see. Diagnosis. How do you diagnose it? Pulmonary function test, spirometry is a good indicator. You can see changes in a chest X-ray. The AT levels, that just looks for the genetic component, alpha antitrypsin levels. ABGs, that tells you exactly what your body's doing, respiratory acidosis or alkalosis. 6-minute walk test, and that's for the person being able to do it's kind of also a functional test to understand their breathing capacity. Let's see what else. I'm looking at my notes. So treatment, smoking cessation is the most effective. Some damage can be repaired over time. Drug therapy, we'll talk about that in the next slide. Oxygen therapy, and that depends on what stage they're in. Airway clearance techniques, the pursed lip breathing. surgery, kind of depending on the cause of the COPD. And this slide, you'll also see this slide when it comes to asthma. Ignore that click to add title marker. But this is also how one kind of stages asthma. They're in specific stages based on their FEV1, their forced expiratory volume. So that's done with your pulmonary function tests. So if they have clinical manifestations and they're only and their FEV1 is greater than 80%, well, then your risk factors, you are always doing risk factors across the stages, period, influenza, pneumonia vaccines, but they're doing a short-acting bronchodilator. What's an example of that? Yes, albuterol or Zopinex. Stage 2, less than 50% forced expiratory volume. I'm sorry, that is actually wrong. It's 50 to 80%. The moderate level. That's kind of red funny. So you're using the bronchodilator when needed, but then you're adding a treatment of long-acting bronchodilators. Add maybe pulmonary rehab, where they're doing exercises to increase pulmonary function. But the long-acting bronchodilator is to decrease exacerbations. We want the patient to have increased function. Or at least have a good quality of life. And then as they go up in severity, they may have inhaled corticosteroids. Very severe, maybe long-term oxygen, depending on their oxygen saturation, depending on some systemic disease. All right, thanks.